Oncology TV here at ASCO 2015. I'm Thomas Baldrick. To my right is Dr. Daniel Ciampi de Andrade. Thanks for stopping by, sir.
Thank you.
So you must be very important with 4 names.
Yes, it's a common thing in my country.
Okay. All right, so thanks for coming all the way from Brazil. Let's talk about this phase 3 study looking at the safety and efficacy of pregabalin. First off, tell us about the mechanism of action with this drug.
So pregabalin is known as an anticonvulsant, and it acts when you have the pain fibers in the first communication, first synapses between the first nerve that carries the pain signal to the second neuron that is in the spinal cord. There's the release of a neurotransmitter called glutamate, and pregabalin decreases the amount of glutamate released in the synapses. So we say that it's a modulator of central sensitization, of the transmission of pain. It doesn't block, it's not an anesthetic, we call it anti-hyperalgesic. So it decreases the gain of inflammation of pain. So in this study you have a clinical problem that is oxaliplatin-induced neuropathic pain and neuropathy. Most patients with colorectal cancer will receive oxaliplatin, and oxaliplatin causes 2 types of neuropathy. An acute one, that is mainly an inflammation of the cell body of the neuron, and it causes insensitivity to cold. Patients cannot tolerate when they take the silverware and it's just cold, they feel pain. When you drink cold water, they feel pain. And this may be even dose limiting for the chemo dose. So, and almost all patients have this acute neuropathy. And some patients, about 15 to 20% of patients, will have a different type of neuropathy that will occur later on. It's a chronic neuropathy that will occur a few months after the end of the chemotherapeutic treatment. Despite these 2 types of neuropathy, they have different mechanisms of action. But it has been shown that if you have a very intense acute neuropathy, you have a 40 times higher chance of having a chronic neuropathy. So our idea was to use a drug like pregabalin that decreases this excessive stimulation of pain signals in the acute phase to try to prevent chronic neuropathy. So we enrolled 206 patients who had colorectal cancer and were going to receive, they had either stage 3 or 4, and they were receiving the modified PreOx scheme. And the interesting thing is that some studies just gave drugs to everybody. So you cannot say you're doing a prophylactic treatment, you're just treating everybody before anything starts. So we try to really do something to protect the patient the moment of the infusions. So we gave pregabalin 3 days before and 3 days after the oxaliplatin infusion, and controlled to placebo. So patients were randomized in these 2 groups. The groups were equivalent and similar in all socio-demographic characteristics, and we followed them for the maximum of 12 months.
So what were the key findings that you discovered?
Well, the main finding is that it didn't work. So it's a negative study from the clinical point of view, and it adds to a large literature of negative studies, because this is a very important issue. 7% of the Western population will have colorectal cancer, and almost all these patients will have at some time contact with oxaliplatin. So we're talking about a lot of people who will have this acute neuropathy with pain, and a proportion from 15 to 20% of patients who have chronic neuropathic pain, which can be really, really disabling and have a negative impact in quality of life. So there's a lot of research trying to find ways to either propose a prophylactic treatment to these patients or to do some intervention to make this neuropathic pain more tolerable. So in a way it's a negative study, but we also, on the good side, is that we have a lot of data on these patients. We have nerve conduction studies, we have skin biopsy, we have blood tests for genetic purposes. Our job right now is to look at the data and try to pinpoint a subgroup of patients that might respond to this treatment. These patients are, we try to have a homogeneous group of patients, but still they are heterogeneous. There's stage 3 and stage 4. Right now we're going to look at the subgroups of patients and try to pinpoint responders and see if we can maybe propose a more tailored intervention to these patients.
Well, you can call it a negative study, but we can also call it a positive effort as you're trying to improve quality of life for patients.
Yes, you're right.
Thank you, sir.
Thank you.
Appreciate your time.
Thank you.